Welcome to the Deep Dive, where we take your complex materials and turn them into clear, actionable knowledge. Our mission today is highly focused and I think deeply critical. We're doing an in-depth exploration of respiratory health. Specifically, we're examining the profound and, well, often overlooked ways that pharmaceutical treatment, the body's own response, and chronic environmental contamination can collide. This collision leads to some persistent, sometimes dangerous issues like mucus overload and dangerously suppressed breathing. This is really a deep dive into finding your breath again.
It is, and this deep dive is built around a really powerful personal testimony. A very meticulous account that directly confronts the severe, cascading, and frankly, frequently hidden side effects of psychiatric medications. Specifically, we're talking about long-acting injections. And this happens when they're combined with the intense stress of navigating a respiratory crisis during a global health emergency. And on top of that, layered over chronic environmental contamination. So we're examining how one individual navigated a period of just intense respiratory vulnerability during the COVID era, and crucially, the exact targeted and practical steps they took to reclaim their lung health, to clear their airways, and to rebuild a kind of deep physical resilience.
So we're not just going to unpack the key warning signs you should never ignore. We're going to get granular on the physiological mechanisms behind mucus overload. How does simple congestion transform into a frightening, even life-threatening situation? Then we'll pivot to the external world, dissecting the environmental factors. So everything from inadequate housing conditions to industrial air quality. Things that can turn chronic respiratory issues into a dangerous systemic cycle. Get ready to understand why the foundational health of your lungs is intrinsically linked not just to your medicine cabinet, but to the very air you breathe and the policies that govern your surroundings.
Yeah, our roadmap starts with that core conflict. The collision of these intense medication effects and the environmental exposure that really triggered the crisis. Then we'll move into the specific science of clearing that deep-seated, entrenched mucus and rebuilding respiratory resilience. We'll look at targeted physical interventions and supplementation. And finally, we'll connect this deeply personal struggle to the broader, unavoidable issues of structural neglect and environmental justice. I mean, this is essential knowledge for anyone seeking to understand the whole picture of their health. Okay, let's unpack this.
All right, so let's begin with the medical and pharmacological context. The story centers on the experience of a middle-aged woman navigating her health during the height of the COVID pandemic. And at the same time, she's receiving a long-acting psychiatric injection called Invega Sustenna. Now, for many people on long-term treatment, managing side effects is just a daily reality. But this source details an unexpected depth of impact this medication and its specific delivery method had on her respiratory system and overall immune health.
What's immediately fascinating here is that the medication created a baseline of extreme vulnerability. This was before any viral or environmental factors even came into play.
Right.
We're talking about Invega Sustenna, which is the brand name for paliperidone palmitate. And to understand the severity of the side effects, you really have to understand the pharmacology. This is a long-acting injectable. It's what's called a depot formulation. It's designed to slowly release the active drug over a really extended period.
And that's the key difference, isn't it? It's not an oral pill you can just decide to stop taking one day. It's a physical reservoir of medication sitting in the muscle tissue.
Exactly. The paliperidone palmitate is suspended in a non-aqueous solvent, and it forms this depot when it's injected. The drug is then slowly hydrolyzed into the active metabolite, paliperidone. This mechanism gives it an incredibly long half-life. I mean, we're talking anywhere from 25 to 49 days, depending on the dose and the injection site.
Wow, that's a long time.
It's a very long time. And this technical detail is vital because it explains why the symptoms persisted. It explains why simply deciding to stop wasn't an immediate solution. The chemical suppression was relentless and persistent.
And the practical consequence of this relentless suppression was what the source calls a cycle of decline. The individual describes developing repeated respiratory tract infections over several months, and they were incredibly difficult to resolve. It wasn't just a series of isolated illnesses, it was this devastating recurring pattern.
And that repeated inability to clear an infection is the clinical signature of severe immune compromise. It really is. The source details how initial symptoms of, say, a cough and fatigue, they didn't just linger, they aggressively escalated into chronic chest tightness, persistent shortness of breath, and a deep systemic weakness. This is where we see the transition from a temporary illness to a chronic respiratory impairment.
It sounds like the body was constantly in arrears, like it was always fighting yesterday's battle while today's new threat was just arriving.
That's the precise analogy. The key indicator of immune suppression here is the recovery curve, or really the lack thereof. The patient noted that each subsequent illness took progressively longer to recover from than the last one.
Okay, so a clear pattern.
A very clear pattern, and that suggests two things. First, that the body wasn't just suppressed, it was being exhausted by the effort. And second, the chronic suppression was preventing the body from efficiently mobilizing its immune cells, the T cells and B cells, that are necessary to clear pathogens and establish immunity. During a crisis like COVID, the source stated every single cough carried this weight of fear, because you simply cannot afford that kind of lingering, unresolved illness.
Let's delve into the medication-induced suppression itself, because this feels like the core physiological mechanism. The source noted that the Invega Sustenna injection caused deep sedation in the body. We need to go beyond just saying it's sedating. What was the physical, the neurological manifestation of that CNS depression on the lungs?
Okay, this is where we move into the mechanics of breathing control. When a powerful antipsychotic causes deep central nervous system, or CNS depression, it directly impacts the brainstem. Specifically, the medulla oblongata and the pons. These are the areas responsible for the autonomic control of breathing. The rhythm and depth that happens automatically without you even thinking about it.
So it's not just making you drowsy in a general sense. It's literally interfering with the brain's ability to tell the lungs to take a full deep breath.
Precisely. It blunts the chemosensitivity of the brainstem. Normally, if your carbon dioxide levels rise in your blood, the brainstem immediately signals for deeper, faster breath to clear the CO2 and pull in more oxygen.
Right, the body's natural safety valve.
Exactly. But deep CNS depression diminishes this sensitivity. The result is significantly slowed and shallow breathing, which is known as hypoventilation. And it's particularly pronounced when the body is naturally relaxed, like during sleep. The individual described waking up feeling profoundly oxygen-deprived, dizzy, and exhausted. That dizziness is a textbook sign of insufficient ventilation and residual CO2 buildup in the system.
That is genuinely terrifying. This wasn't just discomfort. This was a direct physical threat to survival during the most vulnerable hours of the day.
It absolutely was. And alongside the respiratory depression, we see other interconnected systemic failures, circulation slowing down, unstable temperature regulation. I mean, if the body isn't oxygenating properly, the cardiovascular system is struggling. The most critical issue, though, connects right back to the lungs. The difficulty of clearing mucus. Shallow, suppressed breathing means two things. One, the force generated by a cough is weak. And two, the coordinated movement of the cilia, those tiny hair-like structures lining the airways, is often impaired or even paralyzed. The mucociliary escalator, which is the body's natural self-cleaning mechanism, it essentially stalls.
So the medication traps the toxins, it suppresses the breath, which then prevents the expulsion of secretions, leaving the body unable to fight back effectively against any pathogen or irritant that enters the air passages.
That's the perfect storm. The chemical suppression is turning the lungs into a stagnant environment, and you can imagine the psychological toll of this is enormous. The source describes an emotional and physical blur, noting that this respiratory instability affected everything: sleep, concentration, emotional regulation, and just the ability to feel grounded.
I found the description of the painful confusion particularly powerful. Being unable to separate whether the distress stemmed from the mental health diagnosis, the profound medication side effects, or the sheer physical strain of repeated infections. It speaks to a deep form of medical gaslighting, even if it's unintentional.
That confusion is a central part of the trauma. When the physical body is suffocating, when it's experiencing hypoxia, it generates a primal, overwhelming panic and anxiety. These physical symptoms, dizziness, a racing heart, a fear of death, are rational biological responses to a lack of oxygen.
Right.
However, in the context of a psychiatric diagnosis, those physical symptoms are so easily and immediately misattributed to the primary illness. It's just your anxiety, or you're having a panic attack. This blurring invalidates the patient's physical experience, it prolongs suffering, and critically, it delays the necessary physical intervention of addressing the medication or the mucus buildup.
Which highlights the absolute necessity of self-advocacy here. The recovery path really began with the individual meticulously documenting symptoms, not just charting their mood, but charting their breathing, their chest tightness, their fever, and asking pointed questions about immune suppression and respiratory risks associated with these long-acting antipsychotic injections.
That detailed documentation and advocacy were the turning point. It really was. It led to the critical decision to taper off the Invega Sustenna. And we must emphasize again, due to its long half-life and that depot mechanism, this was done slowly, and it required careful medical supervision. Recovery wasn't sudden. The drug clearance is a prolonged, staged process that lasts for many months. This is so crucial for listeners to understand. Patience and precise tracking are non-negotiable when dealing with long-acting injectables.
And once that decision was made and the tapering began, the body slowly started to fight its way back. The source noted tangible benefits. Breathing deepened, constant chest tightness eased, the pattern of recurring respiratory infections finally broke, and energy and clearer cognition returned. It was a physical and mental reclaiming of strength that only happened once the suppression was systematically reduced.
The eventual recovery reinforces that core lesson. Mental stability should never come at the cost of chronic respiratory safety or immune collapse. The medication was achieving one goal while undermining the very foundation of physical life. Recognizing the distinction between physical panic caused by hypoxia and psychological anxiety. That's the first step toward reclaiming physical strength and demanding a comprehensive view of care.
Okay, let's move now to the absolute physical core of the crisis that resulted from this suppression. This terrifying mechanism of mucus overload. This was far beyond typical respiratory congestion. The buildup of thick, viscous mucus in the lungs and chest became the central, frightening, and, as the source says, potentially lethal symptom.
The immediate threat was existential. We have to visualize this congestion. Mucus, or phlegm, it's largely composed of water, mucins, which are large glycoproteins, and inflammatory debris. Under normal conditions, it's thin and slippery, easily moved by that ciliary escalator we mentioned.
Right.
But when you have chronic irritation and impaired clearance, it becomes thick, heavy, and high viscosity. The source describes it as a physical wall, actively interfering with the mechanics of normal breathing.
And that heaviness led to sudden, involuntary gasping for air. So the body was being pushed to the brink, triggering this biological reflexive attempt to pull oxygen into lungs that are physically obstructed by these thick secretions.
That gasping is the body's last-ditch effort to manually override the suppression caused by the medication. It's a moment of hypoxia, low oxygen, signaling the brain to initiate the flight response, even during sleep. And the congestion didn't just affect the lower airways. It was so severe that it caused difficulty swallowing, dysphagia, because the mucus felt physically stuck in the throat and airway, pooling above the vocal cords.
That sensation of drowning while awake, or of the airway being physically blocked, that would trigger a panic that was purely physical, right? Stemming from a biological threat, not a cognitive fear.
And that distinction is paramount for self-advocacy. This wasn't anxiety causing the breathing issues. The lack of oxygen and the physical obstruction were causing the panic. The body was suffocating, and the brain was reacting appropriately. Furthermore, the coughing spells were described as exhausting and persistently non-productive.
Can you elaborate on that? The difference between a productive and a non-productive cough, and why that distinction mattered so much in this context?
Absolutely. A productive cough is forceful enough to clear the obstruction. It brings up phlegm or sputum. It's the body successfully defending itself. A non-productive cough, however, is often dry, strained, and just exhausting. In this case, the mucus was too thick, and the breathing was too shallow due to the medication suppression. So the cough mechanism failed to achieve the velocity required to mobilize these high-viscosity secretions. This failure means the pathogens and irritants remain lodged, which leads to continuous inflammation, irritation, and further cycles of thick mucus production. It's a debilitating loop.
This sounds unbearable, especially when you're just trying to rest. And here's where the crisis intensified into a truly dangerous cycle. The combination of the chronic congestion and the deep chemical sedation from the long-acting medication made sleep nearly impossible, but absolutely necessary for survival.
This is a textbook example of compounding vulnerability and a perilous cycle of suppression. The sedating effects of the Invega Sustenna meant that lying down became inherently dangerous. When you're supine, your diaphragm movement is already slightly restricted, and thick secretions are more likely to pool. This dramatically increases the risk of waking up choking or gasping for air.
So out of desperation.
Out of sheer desperation to get adequate rest, the individual started taking increasing amounts of ibuprofen PM.
And ibuprofen PM contains diphenhydramine, which is a potent antihistamine often used as a sleep aid. and that has its own strong sedating properties.
Precisely. This created a profound and dangerous feedback loop, and we need to underscore the mechanism here for anyone dealing with respiratory issues and medication. Combining any sedating medication, be it a long-acting antipsychotic, a benzodiazepine, or an over-the-counter sleep aid like one containing diphenhydramine, combining that with pre-existing respiratory congestion significantly worsens breathing suppression.
Why does that combination become exponentially more dangerous?
While it reduces the body's protective reflexes, sedation decreases the brainstem's vigilance, making it less responsive to low oxygen levels. You are artificially lowering the threshold for your respiratory drive.
I see.
This increases the risk of aspiration, where material saliva, food, or critically in this case, the pooled mucus enters the lungs. Most importantly, it dramatically intensifies nocturnal oxygen deprivation, which can lead to long-term cognitive and cardiac stress. The cycle was rapidly deteriorating. Chemical sedation led to shallow breathing, which compounded the mucus congestion, which disrupted sleep, which forced the use of more sedating sleep aids, which further suppressed the respiratory drive, worsening the distress.
It's a rapid downward spiral that was entirely predictable, given the pharmaceutical interaction. The education about how these drugs interact with respiratory function was clearly missing or, insufficient at the time, which led to a frightening situation exacerbated by attempts to self-medicate for rest.
It speaks volumes about the disconnect between mental health prescribing and holistic physical care. The testimony lists critical warning signs that were present but initially ignored, emphasizing their seriousness. We should probably run through these because this is essential knowledge. These are signals from the body that demand immediate action.
Absolutely. What are the key red flags of serious respiratory compromise mentioned in the source that people in similar situations should be looking out for?
Okay, start with the congestion itself. Thick chest congestion that would not break up. If you've been coughing for weeks and the phlegm is persistent and dense, that is not normal, and it requires intervention to mobilize. Second, the fundamental sign of failure. Labored breathing at rest or shortness of breath at rest. Breathing should be effortless when you are sedentary. If you have to consciously use your chest muscles just to bring air in, your system is already severely compromised.
Then the sleep indicators, which I imagine are often the scariest.
Yes. Gasping during sleep and shallow or slowed breathing during sleep, these are indicators of serious nocturnal oxygen deprivation. A pulse oximeter, if you have one, would likely show drops below safe levels. And long-term chronic low-level hypoxia has severe consequences for the brain and the heart. Next, the signs of extreme obstruction, difficulty swallowing due to mucus in the throat, persistent coughing paired with exhaustion, the cough is ineffective and draining, and that profound feeling of suffocation even while sitting upright.
And the most severe medical red flags mentioned are non-negotiable emergencies, right?
Absolutely non-negotiable. Blue or pale lips, cyanosis. That is an emergency signal of critically low blood oxygen levels. It demands immediate hospitalization. Lingering fever means the body is locked in an unresolved fight against an infection. And the final critical point for this population, extreme sedation paired with choking sensations. This cluster indicates the failure of the central nervous system to maintain life-sustaining respiration. It must be treated as a physical medical emergency, separate from any psychiatric diagnosis. These are not signs of anxiety. They are signals that the physical machinery of breathing is failing due to obstruction and suppression.
So the narrative transitions here from crisis to a deliberate act of recovery. We're moving into the healing phase, detailing the physical interventions and supplements used to support lung health after that critical decision was made to taper the medication.
Right. The first essential step, as we established, was removing the continuous source of pharmacological suppression by slowly tapering the in vega sustenna. But the crucial insight from the source material is that simply removing the medication wasn't enough to instantly solve the physical injury that had accumulated over months. The deep-seated high-viscosity mucus that had been trapped by the suppressed breathing did not immediately disappear.
So the body was no longer being actively suppressed, but the environment created by that suppression, the trapped mucus that remained. Active, targeted support for the respiratory system was necessary to clear the chronic congestion that had been lodged for so long.
This is the pivot point from passive withdrawal to active intervention. The first critical tool introduced was the use of mucus relief expectorants. Expectorants, which often contain guaifenesin, are absolutely crucial here. They are designed to thin and mobilize the congestion in the chest.
How does an expectorant actually work on the mucus? What's the chemical process there?
Well, expectorants work primarily by increasing the volume and reducing the viscosity of secretions in the respiratory tract. They're thought to stimulate the production of thin, watery mucus, which then mixes with the thick, viscous mucus that's trapped.
Okay, so you're watering it down, essentially.
You are. By effectively adding water to the sludge, the total secretion becomes thinner and more easily moved by the weakened ciliary action and the force of a cough. It turns that non-productive, dry struggle into a productive, clearing cough. And this is fundamentally different from a cough suppressant, which in this scenario would be incredibly dangerous because it would just leave the trapped mucus right where it is.
And the source describes the immediate, palpable relief once this process started. As the mucus began to break up and the airways opened, the individual's coughing became productive. It replaced those strained, dry, exhausting spells.
It's the physical sensation of the body finally getting its drainage system back online. Once the obstruction begins to clear, the lungs can finally feel the freedom of full expansion, and the constant burden of fighting against that wall of phlegm is lifted. The second key intervention mentioned, and one that provides a high level of technical detail for our deep dive, was the introduction of a supplement, N-acetylcysteine, or NSC.
Right. NAC. It's constantly referenced in discussions about recovery and immune health. But here, it was added specifically to tackle the long-term respiratory and inflammatory damage. Let's dive deep into the specific documented benefits that made NAC so invaluable in this particular crisis.
This is where we elevate the conversation from just supplement talk to cellular biochemistry. NSC is essential because it is a direct precursor to glutathione, which is often called the body's master antioxidant. The chronic infections, the environmental exposures, and the inflammation, all of that rapidly depletes the body's natural glutathione reserves. Supplementing with NAC helps the body replenish those reserves, providing systemic protection.
So it's not just about the lungs, it's about repairing the cellular damage caused by months of fighting.
Exactly. But its function is multifaceted. The first benefit, and the most relevant to clearing the airways, is its direct action as a mucolytic. Unlike expectorants that add water, NAC chemically helps break down the structure of the thick mucus itself.
How does it chemically break down the mucus?
Thick mucus strands are held together by strong chemical bonds called disulfide bonds. They link the mucoprotein molecules together, creating that high viscosity. NAC acts as a reducing agent. It literally cleaves or breaks these disulfide bonds.
So it's like a chemical scissors.
It's exactly like that. Think of the mucus like a tangled ball of yarn. NAC is like scissors, chopping the thick, matted strands into shorter, thinner pieces. This dramatically lowers the viscosity and allows the newly thinned mucus to be expelled much more easily.
That is fantastic detail. So it's both reducing the viscosity and strengthening the body's internal defenses simultaneously.
Precisely. And beyond the mucolytic action, NAC has 3 other critical benefits in this context. Second, by reducing inflammation and clearing obstruction, it directly supports lung function, helping the compromised lung tissue operate more efficiently. Third, it plays a massive role in reducing oxidative stress. Chronic inflammation from repeated infections and environmental toxins generates harmful free radicals that damage lung cells. NAC provides the antioxidant power to neutralize that damage.
And the fourth benefit ties back to the idea of detoxification, right?
It does. It assists the body in detoxifying inflammatory byproducts associated with chronic, unresolved infections. When you have months of viral and bacterial presence, the body is left with this toxic inflammatory residue. NAC aids the liver and immune cells in clearing that debris, helping the immune system reset and rebuild its capacity. The overall result was tangible. Easier management of chest congestion, smoother breathing, and crucially, improved resistance to repeated infections. The individual was finally breaking free from the constant cycle of toxic buildup and respiratory strain.
So we can synthesize this recovery path into a crucial, multi-pronged approach. It required both withdrawal from the medication and proactive physical support. This wasn't a quick fix. It was a fundamental physiological reset.
Absolutely. True respiratory healing in this context required 4 key stages. Stage 1, stopping the source of suppression through that slow, medically supervised tapering, acknowledging the long half-life of the drug. Stage 2, rebuilding lung clearance using targeted tools like expectorants and NAC to physically mobilize and chemically break down the trapped congestion.
Right.
Stage 3, strengthening immune function through reduced stress and supplements like NAC. And stage 4, which is often overlooked, allowing time for the body to heal its natural breathing rhythm, to retrain the autonomic nervous system to breathe deeply again, free from chemical suppression.
The personal lesson here is that recovery from this kind of deep physical injury is an active process. It goes far beyond just managing the mental health diagnosis. It requires understanding the specific mechanics of the physical damage and using targeted physical interventions to reclaim your breath.
And now we shift our focus from the internal factors, the medication and the physical response, to the external forces that converge to create what the source aptly calls a perfect storm of vulnerability. The experience made it unequivocally clear that true healing requires confronting the full spectrum of environmental and medical forces at play.
The source states that the respiratory distress was caused by a convergence of, well, a lot of things. Environmental gases, viral exposures, and/or toxins, and the immune suppressive effects of Invega Sustenna. We've spent time on the medication and the viral exposure context of COVID, but we have to look closely at the environment the individual was forced to inhabit.
The context provided, living in mental health housing, is crucial here. This setting often exposes residents to chronic contaminants that are rampant in underfunded, poorly maintained, or just neglected communal living situations. The specific hazards listed are shocking, and they reflect a structural inequity. We're talking poor ventilation, mold growth, which indicates water damage, pervasive chemical odors from industrial cleaning agents, and unstable sanitation.
I want to focus on the indoor contaminants first. What exactly is the danger of pervasive chemical odors in a poorly ventilated space? I mean, it sounds like simple cleaning, but it becomes toxic, especially to compromised lungs.
It becomes a critical source of chronic inflammation. When the ventilation is poor, volatile organic compounds, or VOCs, from strong cleaning agents, think concentrated bleach, ammonia, aggressive synthetic disinfectants, they build up and linger in the air.
Okay.
These are direct respiratory irritants. They chemically irritate the mucosal lining of the nose, throat, and bronchi. And this is often exacerbated in these settings by people mixing cleaning chemicals improperly.
Yeah.
Sometimes they can accidentally create corrosive gases, like chloramine gas, which is profoundly damaging to the airways.
And mold is a whole different category of biological hazard, right?
Yeah.
It often releases mycotoxins.
Absolutely. Mold spores release mycotoxins, which can trigger severe allergic and inflammatory responses. For a person already fighting chronic infection and immune suppression, mold is not just an irritant. It's a constant, low-grade source of systemic assault that fuels mucus production and keeps the lungs in a state of hyperreactivity.
But the contamination wasn't just consigned to the inside. There was also continuous exposure to exhaust fumes, smoke, and industrial byproducts. So significant environmental gases and hazardous pollutions stemming from the surrounding neighborhood.
This is the external burden of environmental injustice. These conditions, often a result of zoning that places low-income housing near industrial corridors or high-traffic areas, they mean viral infections and environmental irritants circulate freely. They continuously attack already compromised lungs. The air is never clean enough for the body to rest.
Let's discuss the mechanism of external environmental damage in detail, because this is where physical health meets policy and urban planning. How do these external pollutants physically harm the respiratory system?
Overexposure to these gases, fumes, and industrial emissions creates a direct pathway to decline. The most dangerous components are often microscopic particulate matter, especially PM2.5. These are particles that are 2.5 micrometers or smaller. They're small enough to bypass the nose and throat and penetrate deep into the lungs, reaching the alveoli, where gas exchange occurs.
So they aren't just irritating the surface, they are actively interfering with the fundamental function of breathing.
Precisely. They create localized inflammation and oxidative stress deep in the lung tissue. This constant irritation forces the lungs to work harder just to achieve adequate gas exchange. And the body's defensive response is inflammation, swelling of the airways, and crucially, excessive chronic mucus production. It's designed to try and trap the foreign invaders. This mucus, in turn, clogs the system further, creating difficulty breathing even before an acute infection takes hold.
So these irritants cause early signs of suffocation and oxygen deprivation before an infection is even visible, simply by creating inflammatory swelling and chronic mucus buildup. It's a foundational weakening of the system.
It is a gradual erosion of respiratory capacity, and when you combine this relentless environmental irritation with the vulnerability caused by the medication, the inability to clear the airways due to CNS depression, that's the compounding vulnerability we discussed. When the immune system is already compromised, whether by chronic stress, poor nutrition, or immune-suppressive psychiatric medications like Invega Sustenna, it simply cannot cope with the constant onslaught of pathogens and irritants.
And these pathogens are easily transmitted due to overcrowded settings and poor ventilation, which the source explicitly ties to the realities of underfunded mental health facilities and community housing.
The interaction forms a devastating cycle that is systemic. Irritants from poor air quality damage the lungs and cause excessive, thick mucus. Infections then exploit that damage and enter easily through overcrowded settings. The resulting inflammation and scarring further erodes the body's already weakened capacity to heal and clear itself. The body is fighting the medication, the infection, and the air itself all at once.
This brings us to the political and structural dimension that the testimony posits. It states that respiratory illness in these settings is the predictable outcome of structural neglect and environmental inequality. This pulls respiratory health out of the purely biological realm and into the socio-political realm, making it about justice.
That synthesis is the most critical realization. It means that the high respiratory risks faced by marginalized groups, including mental health consumers and low-income communities, are not random acts of bad luck. They are the direct, measurable result of being systematically positioned in environments shaped by policy decisions that prioritize industrial or traffic corridors over residential health, often referred to as environmental redlining or disinvestment.
In essence, the quality of the air we breathe and the safety of the indoor spaces we inhabit. It's influenced by policy and industry, which makes respiratory health a political and environmental issue, inseparable from mental well-being and recovery.
When policy permits unsafe housing conditions, poor ventilation, and the proximity of industrial pollution near marginalized communities, that neglect translates directly into chronic physical illness. It requires a massive expenditure of energy just to breathe. The source makes a powerful, undeniable case that the deterioration of health in these environments is not an isolated medical event, but a systemic failure to protect the basic physical well-being of those who are already vulnerable. The recovery detailed in Section 3, clearing the airspace, reducing chemical exposure, required removing the individual from this cycle of structural neglect in order to truly heal the body.
So our final discussion point synthesizes all the key knowledge gained and iterates this call for recognition and proactive change. The deep, hard-won personal lesson here was that respiratory health and mental health are fundamentally and inextricably connected. You simply cannot treat the mind while the body is suffocating.
Recovery became possible only when toxic exposures were drastically reduced, when harmful environments were changed, and when the body was no longer forced to fight medication side effects and adverse living conditions simultaneously. It was a simultaneous withdrawal of harm, pharmacological, environmental, and structural.
So the essential steps were deeply interconnected. Clearing the physical airspace and reducing chemical exposure went hand in hand with strengthening the immune system through targeted support like NAC, and fundamentally re-evaluating the treatment plan to remove the source of pharmacological suppression. It was a holistic intervention.
And this leads us to the critical takeaway for listeners, a theme of radical self-validation. Symptoms are messages. They're not inconveniences. The source emphasizes that no one should ignore persistent respiratory distress or endure contaminated housing conditions in silence. The feeling of suffocation is a rational response to an environmental threat, not a sign of mental fragility.
Healing starts with listening to the body and proactively removing the harms that suffocate it. Symptoms like persistent shortness of breath, chronic chest pressure, and relentless mucus buildup. They are the body's communication system. They are demanding attention, and that attention must include a rigorous medical evaluation to rule out medication side effects, an exploration of targeted supplements like NAC for cellular support, and a critical look at the air quality and toxins in your living environment.
And for pure mental health communities and advocates, this knowledge is a blueprint for collective resilience. Understanding the profound link between policy, environment, and physical health empowers individuals to demand better standards of care and safer living conditions. This shifts the blame from the individual body, which is simply responding rationally to toxic input, to the systems that permit the toxicity.
This empowerment has to translate into specific advocacy goals, because policy failure directly equals physical harm. We need to demand safer housing standards, cleaner air standards, and transparent health practices that rigorously assess the respiratory risks of long-acting sedating medications.
When communities rise with this knowledge, they gain the power to reshape environments and influence policy. It inspires a new standard of justice where every breath counts. We are not merely recipients of care. We are knowledgeable advocates for our whole health. And we must demand systems that honor and protect the foundational mechanism of survival, the breath.
Today we journeyed through a powerful and, well, sobering narrative. We identified exactly how a long-acting medication like Invega Sustenna can create profound respiratory vulnerability, especially when it's layered over chronic environmental toxins present in structurally neglected housing. We saw the terrifying mechanics of mucus overload, the chemical science behind why it gets trapped, and the critical role that targeted interventions like expectorants and the powerful mucolytic action of N-acetylcysteine can play in physical recovery and resilience building.
What's truly eye-opening here is the immediate chemical response of the lungs to danger. Whether that danger originated from airborne industrial chemicals, a viral exposure, or the profound physiological suppression caused by a long-acting medicine, the body's reaction was consistent. Inflammation, mucus buildup, and compromised breathing. We learned that the immune system, the environment, and pharmaceutical side effects, they don't operate in isolation. They converge to either support or systematically suffocate the body.
And we explored the necessity of confronting the structural neglect that makes environmental harm a predictable, systemic risk for marginalized groups. The air you breathe is, in a very real sense, a measure of the system designed to support you.
If our breath is the primary mechanism for survival, and the quality of the air we breathe is often defined by policy, urban planning, and inequality, this raises an important question that requires deep reflection. What structural changes must we, as informed advocates, immediately prioritize and push for in our own communities, in our housing regulations, our city planning, and our healthcare transparency, to ensure that the basic, non-negotiable right to breathe freely is protected for everyone, regardless of their background or current medical status? Think about the air quality and the spaces you inhabit every day. Is that environment supporting your cellular health and resilience, or is it silently taxing the deepest processes of your body?
Thank you for joining us for this deep dive. We hope this knowledge empowers you to be a detailed, informed, and relentless advocate for both your mental clarity and your physical strength.